season. So I'm going to talk to you today about our Heart and Lung Wellness program. I came over to clinic administration in June of 2016, and at that time I was given the task of setting up a heart and lung failure program. And in the value-based world, what we're trying to do is get our arms around the really high-cost, high-risk patients. So I come from the women's health arena, and I was told, go set this up. And so what we did was we really looked at what we had in place in primary care, and we have had a really robust patient-centered medical home for probably 9 years or so. And so we took the medical home philosophy and we moved it out into the specialty clinics. So we took our health coaches, that model, and we hired very highly experienced nurses that had worked in the cardiac and pulmonary world, and we happen to have one sitting in the back of the room right here that we may call on later, Laura, who's one of our care navigators. But so we kind of moved the whole medical home concept into a specialty clinic, which was kind of cutting edge a little bit. So that is kind of how we started this journey. And so I thought I would share a little bit about population health. Part of my job is working on population health initiatives, which this is one, and the other part of my job is working on patient experience initiatives and how we make sure that at every touch point along their journey, our patients are having an extraordinary experience, and we exceed their expectations. So I saw this somewhere and I went, oh my God, that's so it, because we're all trying to grapple with what population health means and how, how do we work within that world? And so David Kindig and Greg Stoddart introduced this term in 2003, and they defined it as the health outcome of a group of individuals, including the distribution of such outcomes within the group, which refers to the distribution of health outcomes within a population, the range of personal, social, economic, and environmental factors that influence the distribution of health outcomes and the policies and interventions that affect those factors. What a mouthful. So it's really, why does one population fare better health-wise than another population? And then what do we do when we're looking at social determinants and where our people live to make sure that we are providing them all the things they need to have optimal health? So why do we focus, why was this my task? And this is straight off the CDC site, which I think is all telling. 86% of the nation's $2.7 trillion in annual health care expenditures are for people with chronic and mental health conditions. And 1 in 2 adults in the United States has a chronic disease. 1 in 4 has 2 or more. And they're the costliest patients that we have. Okay, and so heart disease, cancer, chronic lung disease, stroke, Alzheimer's, diabetes, and chronic kidney disease are all included in those high numbers of those. So in 2016, I came and they said, go do this. And so we started hiring these high-risk health coaches to help with the CHF and COPD patients over in our cardiopulmonary clinic. And so what they did was they tried to really connect and engage these patients and identify what their, individualize those treatment plans to the patient and what they found, what they understood, what did they identify as important and goals, and how could we make sure that we are supporting them with these chronic terminal illnesses, they could live at the highest functional status. One of the things so in cardiopulmonary, they had never had that level of nursing care. So when we brought these nurses in and we said, now you're going to care manage their patients in an outpatient setting, the docs were like, who are these people? And they have nurses, but they don't work this way. They don't care manage people. So that was a challenge, and it was kind of interesting because we took baby steps for a while, and now I think if you would go to the cardiologists and pulmonologists, they would say, we couldn't live without these nurses. they take such good care of our patients, and our patient outcomes are so much better with them in place. So the clinics kind of have been struggling with this for many years. When a patient comes out of the hospital and they have heart failure or COPD, they had access issues getting back into the specialist in a timely manner. And you know, a lot of times they need titration of medicines, and I mean, it takes a while to get them to where we've got it all figured out. And actually, we probably never have it all figured out because we're always adjusting things. These terminal illnesses, they wax and wane. So sometimes they do pretty well, and then they have exacerbations, and then we kind of start all over. So they couldn't get into cardiology. So when they were discharged, they were many times seeing the PCP. And then we had all this disconnect in the care. So there wasn't good communication between specialists and the PCP. There wasn't communication between the staff, the health coaches in primary care, and the staff in cardiology. So that was a huge part of what our care navigators do, is they really are that bridge between primary care and the specialists. And so we do a lot of the communication through Cerner, and that way the PCP knows when the cardiologist or pulmonologist are making changes to the treatment plan. So it's still, I think we have a pretty good handle on the Cerner stuff, but then everything outside of the hospital, then we're just like, oh my gosh, we've got SNPs and home care and DME and blah, so it's a huge challenge. A lot of what these guys do is they just do so much teaching with the patients so that they know warning signs, and so they would know if I'm getting into trouble, I can talk to my care navigator, and then we try to get them in the clinic. And that's another challenge we had, is daily access. Like, how, if they're having an exacerbation, do we have somewhere to put these patients so they can be seen in the clinic and not just sent to the emergency room? So, and our other goal is just to help increase the quality of care that we're providing, reduce the total cost of both of those conditions. So one of the things we really had to talk about is if we were up for the challenge of providing this type of managed care to this really sick and complicated patient population. So we're just committed to making the patient our partner, and many times that means the patient and the son and the daughter and the rest of the extended family. And the conditions in which we live, or where our patients live, explain a lot about why some are healthier than others, and so I'm going to talk a little bit about the social determinants. We need to commit to developing a deep understanding of this really clinical diverse population and avoid stereotyping. I mean, they're not just non-compliant because they're, poor, or because they're, we really need to dig in and figure out what are the challenges that are keeping them from being non-compliant. And the other thing is, there's so much thrown at these patients, and in just healthcare in general right now, it's so hard to figure out anything. And if you're chronically ill and elderly, it's hard to understand what we're trying to tell them. And so we really look at it, if we can get one behavior to change and celebrate that, give them a confidence, you can do it. See, you can do it. You change that one thing, then we're on to something. So these patients often have extremely functional limitations which impact their ability to care for themselves. They many times have complex social needs. Care tends to be fragmented and confusing. It's just, it's a wonder that more of these patients don't end up in the hospital, right? Some have significant behavioral health challenges, and as we all know, that is definitely an area where we're lacking as a community and as a country. So, and we need to keep in mind that not all of these patients are at the end of their life. So congestive heart failure and COPD are terminal illnesses. And what we don't do a good job of, in my opinion, is when they get those diagnoses, really start talking to them about what that means and what this journey and their disease trajectory is going to look like. We can't totally predict it, but we have a pretty good idea. And so what is important to these patients? And start having those conversations early on. And we're going to talk about NIDO and some of that stuff later on, but we need to set their goals and personalize their care to what's important to them. I loved this that I found in the British Journal of Medicine. The goal is not to cure, it's the maintenance of pleasurable and independent living. And I do think that's how our nurses manage their patients, is just with that goal in mind. So the impact of social determinants of health, and this was from the Healthy People 2020 site, but social determinants of health are factors in the social environment that contribute to or detract from the health of individuals and communities. They've been found to directly increase the burden of heart disease and stroke and their risk factors. They also indirectly influence health-promoting behaviors. And so when we're talking about that, we need to look at all of these things and think about this in our community and how this impacts all of our populations. And Omaha is we are pretty lucky in our health system with the population that we deal with, but our community has many, many challenges. So we need to look at these things. Economic opportunity for our community, job training. Are people unemployed? Are they living in poverty? Do they have the means to even get the medications we're asking them to get? Quality of education. Can they understand what we're telling them about their disease? I mean, when you look at health literacy across the country, people don't understand what we're telling them. And we use medical jargon sometimes, and we don't do teach back. And so do we really know if these patients understand what it is we're trying to tell them and teach them about their meds or a change in their treatment plan? Language barriers. Are we addressing that? And does everyone that's involved with the care of the patient understand that we need to get an interpreter or have someone that signs? Or is it clear in the record that we need that? Where are our patients living? Do they have a safe home? Do they work in a safe place? Are they exposed to crime? Is their food, air, and water clean? And do they have access to healthy, nutritious food? That's a huge part of our heart failure patients, right? I mean, they go eat high fat, high salt. On Saturday, they're 10 pounds up by Monday, but can they afford to get healthy food? And this all has to be taken into consideration when we're devising care plans very specific to each patient. What kind of support do they have in their home and neighborhood? The nature of our patients' social interactions and relationships. So one of the things that, from a population health standpoint, that we're looking at, there's been a couple things I've been involved in recently that I'm really encouraged about. One is I went and toured a clinic in Lincoln that is associated with Lutheran Family Services, and it's a 360 integrated clinic. And so they have social workers embedded in their primary care office, and so they serve a very high-risk population. And so when the patient is in with the provider, if the provider identifies this person's non-compliant, they're really stressed out, they've got all this stuff going on, the social worker, whose title is a behavioral health consultant, the doc comes out or the provider comes out, the social worker goes in and spends 15 minutes doing a brief intervention with the patient about this issue right now. What are the coping skills I can give you to deal with this right now? And then she's a social worker, so then she would, in talking to the patient, if they identify they can't afford their heat bill or they can't afford their rent, she knows about the community resources that she could tap into to help them with that specific issue. So I loved that model. I thought we got to find somewhere to pilot that in our primary care clinics. And then the other thing is we've been working with the Douglas County Health Department on community health workers. And these are individuals that are lay people that are trained to be support people in the community. And I think we definitely have some areas in physicians' clinic where we could partner those community health workers up with very specific populations. And so this is a project that the county and the city are really getting health systems and different agencies involved in. So we're working on job descriptions and training, and so those are things that I think can help us with this kind of social determinants and how we support the people in the community to be more compliant with their care. Just a couple examples. The keys to success for our program is identifying the high-risk patients, connect them with the care navigator, either in the hospital or in the clinic, and I'll talk about that in a second. Close working relationships with the hospital care management staff, and we do. We know we actually talk frequently with the care managers at the office or at the hospital. Hospital follow-up care is provided by specialists within 3 to 5 days following discharge, and this is a best practice nationally for heart failure, especially COPD. The literature maybe is more 7 days because they need to be on those inhalers for a while before you see if they're effective. So we have put in place, we have on the Nebraska side, we have 4 care navigators. One is at the hospital, and 3 are at the office. 4 at the office. 4 at the office, one is that we just hired another one. One is at the hospital. That is new. When we started this program, one of our goals was we wanted to have the care navigators in the clinic go over and meet the patient in the hospital and say, I'm going to be your care navigator, and so I'm going to just help guide you through this transition going home or wherever you're going, sniff, but then I'm going to be there for your follow-up. But they couldn't get out of the office, and so we couldn't get that accomplished. So what we did was we hired a care navigator specifically for the hospital. So her office is at the hospital. She does go to the clinic to see patients every now and then, but that has been great, and we're going to talk about cardiac bundle payments a little bit, but that's been really helpful as we're trying to go down this bundle payment journey with her getting her arms around the CHF patients that are in the hospital getting ready to be discharged. So, and she's really, really being embedded in the hospital. She's really connected with the hospital care management team, discharge process. So that's new. We just started that in July, so we're excited to see where that will take us.
How does she get notified if she has a patient in the hospital? There's a consult.
Mm-hmm. Yep. And the care managers and the hospital staff, too, they're getting to know her more. So it's Terry Meidlinger. I don't know if you guys know her. She's been around forever. She's fantastic. But yeah, so so we're trying to keep this big spreadsheet on these patients. So we have a scheduling person. She's kind of our mom, our office mom. Her name's Anna. So Terry talks to Anna. Anna makes sure the appointment gets made. We're trying to hardwire this a little bit, but it's been really great. So it will be. I'm excited for like 6 months out to see what it looks like. So anyway, we've got our care navigators on this side. We have one care navigator on the Iowa side. Both of the cardiology and pulmonology groups have APRNs that work for them, do hospital rounds, are procedure-oriented. On the Iowa side, one of the physicians over there last October said to his partners, we are going to have a heart failure clinic in our clinic. So when these patients get out of the hospital, we will be booking their follow-up appointment before they leave. And you can either see them or the APRNs are going to see them, but they're going to be seen in the hospital or in the clinic within 3 to 5 days. So that's done over in CB, plus we have same-day access. So those APRNs, if a patient's having trouble, those APRNs will see the patient, come to the clinic before you go to the ER. Let's see if there's something we can do. Is there an intervention we can do? So we when was that, Laura? Just a month ago? Now have the same process on the Omaha side. So we have Terry talks to Anna, like I said. Anna books the appointment, and either they see the doc or they see the APRN. And these cardiologists do so much outreach around the communities around southwest Iowa and Nebraska that for them to do a follow-up within 3 to 5 days is highly unlikely. So we've got time carved out now with the APRNs. So anyway, that has been a huge celebration for us because we've been working on that for 2 years and we finally got it done. But so now we feel confident that we can get that quick follow-up, hands on the patient, eyes on the patient, and if they have any kind of issues, and the care navigator feels like they need to be seen, we have somewhere to put them and they can come in. So these guys do so much education with the patient, and it's been nice. Elaine and we've been working on standardizing our education for CHF and COPD for several years. We finally have everybody on the same page about the teaching that we use. In fact, we've taken what the hospital used to use over to the clinics with the calendars and the workbooks and things like that. So I think everybody on both sides of the river, we're all saying the same thing as far as the action plans. And so that's been nice because the patient hears it over and over and over. We're really trying to work on making sure that our health coaches in the primary care offices are familiar with that as well and that they understand it and feel comfortable with it. They're really good at diabetes. They're a little nervous about these other chronic conditions, so we've been trying to give them some extra training about that, but because the care navigators cannot follow all the CHF patients, and nor should they, because not all of them are in an acute phase of their illness. We like to promote self-care, including self-adjustment of diuretic therapy in appropriate patients. So if a patient understands what changing their oral diuretic meds means, and the care navigators feel confident with that, they have some standing orders they can use to adjust that if they need to. We also give IV Lasix in the clinic on both sides of the river. So if a patient is having some fluid overload, they can come in and we can give IV Lasix there instead of them going to the ED, because we know if they go to the ED, they're probably going to get admitted. So we have that option. Optimized medical therapy with emphasis on behavioral strategies, and I think we've covered those things. So why a care navigator? The CHF and COPD patients that are newly diagnosed or discharged from the hospital often feel confused about their new medications, treatment plan, and the conditions that they must now learn to manage and live with. And so that's kind of what we talked about. It's just a lot to take in. They're very overwhelmed. Patients get discharged with a novel. They can't discern which is the most important stuff they should pay attention to. And they're scared. They're very, very vulnerable. This makes them excellent candidates for a higher level of health coaching and referral into the Heart and Lung Wellness Program for close oversight and partnering with the care navigator. The care navigator is focused on coordinating care across the entire care continuum, advancing care plan progress, providing ongoing patient self-management support, and fulfilling other complex needs as they arise. So these RNs, highly skilled RNs, they're embedded in the cardio and pulmonary clinics, and they manage the highest risk and highest cost patients. They work with patients to ensure they understand, agree with, and participate in the management of their chronic conditions. And these are the things they do all the time. Understand and have a reliable medical management strategy, overcome barriers to follow-up appointments, know how to recognize and respond to their symptoms, setting goals. And I think I have, so this, I put at the bottom here, meds, 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 meds. This is what they are unrelenting when it comes to med reconciliation, and they don't stop until they figure it out. But they spend a good portion of their time on trying to figure out what medication is correct, is the dose correct, did it get changed between their transitions, between hospital and SNF, SNF and home, home and hospital. Can they afford them? If they can't afford them, what are the resources? Does it need pre-authorization? I mean, they spend a good amount of their time on med reconciliation, but I'm just so proud of them because they just will not stop until they get it figured out. So the other thing is they devise their care plan for the patient based on the needs of the patient. Some of these patients they call every day. Some of them they call every week. They try to always be at their appointment with them, especially when they're first coming out of the hospital. And that way, they're in the room with the doc and the patient, hearing the discussion, and then they can really follow up on what the doctor's telling them in terms of the treatment plan or any change in their medications or whatever. So that has been huge, and they can't be everywhere at once. They've got phone calls, and their phone calls last a long time. These patients have lots of questions, and they come to rely on these people, and then they just like talking to them too. But so they can't be everywhere. So sometimes they can't get to their appointment because they're on the phone, or it's just they do the best they can and really prioritize their work. So sometimes they remind the patients. They call, remind them, do you have transportation? Can I help you with that? Can I make a call for you? They can schedule nurse visits. So if they think this patient just needs more education, they can just have the patient come in and they can sit with them by themselves and go over teaching. Again, meds. They support self-care behaviors, taking meds as prescribed, monitoring weights. We give them scales. We have scales in our office. So I think we try not to give those out at the hospital too much. We try to give them out in the clinic. And we get those from the foundation, which has been fantastic. They've been wonderfully supportive. And just, again, staying active, following low-salt diets, recognize symptoms. This is a this is a pill pack. And so we are in a pilot right now, or working on a partnership with Elmwood Pharmacy. And Elmwood has 3 pharmacists, and they have 4 drivers, and they split the city up into 4 quadrants. And so right now when our heart failure patients are discharged, and if the family's agreeable, we have a pharmacist from Elmwood that will go out into the home for about a 2-hour visit and do med reconciliation in the home. They gather up all their meds, and then they make these pill packs for them so that they know exactly what you're supposed to take when. Theirs has pictures of the pills so they know what the pills are. And then they take all of their other meds back to the pharmacy and they say, I'm going to repurpose what I can and I'm going to hold the rest of them for you. So patients don't take them. And so we're just starting that. And the cardiologists and pulmonologists with these pill packs, they're loving that. And I know that Elmwood's not the only pharmacy that does this. There's online companies that do it as well, but we're really starting to explore what that looks like and if we can encourage our patients to make that change of pharmacy so they have that better level of service. Elmwood stays in touch with the patients for 6 months. If there's a change in their medications, they send out like what's changed, have the driver go out, pick up this pill pack, take it back to the pharmacy. They have the meds they need for 2 days. They redo the 2-week pill pack, send it back out the next day. So
I was curious if there's an extra charge to do that packaging.
There's whatever their copay is right now, and then if they buy the 90-day supply of meds online, they will charge them like $30, I think it is, to put it in the pill packs. But depending on how that program grows, there could be a nominal fee for them to manage our patients in a program, but right now there's not. So, but it's a fabulous service. And so how we kind of contacted Elmwood Pharmacy is the care navigator said to us, Elmwood Pharmacy, they are digging us out of holes. Like when no one else can figure it out, we call Crystal, and Crystal figures it out. So their level of service is just phenomenal. And again, not saying that there's not other companies in town or pharmacies that will do the same thing, because I think that's probably where pharmacies are going to have to go. But and we'll explore that. But right now, we're just going down the road with them.
Well, the other thing is that Elmwood would be like depending on the patient, you may not be able to make a change for 30 days because the patient doesn't understand the drug. So
Yeah, yeah.
Do you charge the patients for that 2-hour visit when they go out there and clean up all the medicine?
No, it's part of their service. And like I said, if they're, so we don't, they don't have 500 of our patients right now. That could change if they do, and they have to start hiring more pharmacists. I don't know. But right now, it's part of their service.
So is it just for the pilot that they'll go in and do this, or they just do that?
They have done it, they have worked with the infectious disease department at the Med Center with HIV patients. I think that's the other place where they've done it. So, and I think, I just feel like they are really a community-based, I think they've done it for other high-risk patients. They've got some fun stories about, if they just feel like a patient really needs that level of care and education, who better to do it than a pharmacist? And their owner that's just his philosophy, really, is doing the right thing. Now, they don't have, like I said, they don't have 500 of our patients. It's hard to believe that they could manage that with a huge patient volume and not charge for it. But they're pretty fantastic, right, Laura? They've helped us a lot. The other thing, we have to really partner with the primary care health coaches, because these guys are really focused on CHF and COPD, our care navigators. And so they're not managing people's diabetes, right? So they have to, we're really trying to learn how we collaborate between primary care and specialties, physicians and staff. So our care navigators really have to work with them on, this person's diabetic as well, and they need some help with this, and you're going to have to take this one because I don't do diabetes. So we're really trying to really be a pretty robust care team that involves different locations even. And then just transitions of care. There's so much going on in the health system right now with how we do this and try to keep connected and make sure that we all are on the same page of how we're transitioning patients through office to ED, ED to home, ED to hospital. I mean, but we could just map this out, and it's just insane, all the touch points that these patients have. I don't know if you guys have heard, but MPC has a SNFist team. I have 4 APRNs and 2 physicians, and they're embedded out in the facilities. We have 5 facilities right now. But Methodist Health System has entered into a partnership with 12, I believe it's 12 facilities throughout Council Bluffs, Fremont, and Omaha. And we have next week our first meeting to work on our charter. But the beauty of this is that, and we can't force our patients to go here, but we can tell them, we have physicians and a team in these facilities. We're partnering with these other facilities. And when we partner with them, we're working on quality. We're working on access. They need to be transparent with us about if we identify something that's a challenge, what are your steps you're taking to mitigate it? And we need to see your quality metrics. So we're excited about that. It's funny because when we've met with Elmwood, what Elmwood has told us is that the med rec coming out of a SNF is by far the most complicated and tough project they work on. Hospital is one thing, but he said SNF, it's like we got to do something there. So this, hopefully, we can really dig in and see why is that such a problem with our partners here. Home health care partners, it does take a village, so that's something that we're going to be working on. The health system has a preferred, VNA is our preferred home health care partner. And so we haven't had a chance to really sit down with them from the clinic standpoint and talk about challenges and quality, and so we're hoping to do that soon. And then again, just our community partners, we've really tried to get our staff educated about the 211 program with United Way, Community Alliance, Eastern Nebraska Office on Aging. I mean, we have to rely on our community partners to help us manage all of this. So we just continue to try to educate and develop our relationships with these different agencies. So how many of you have heard about NITO? And so NITO stands for the Nebraska Emergency Treatment Orders, which is advanced care planning. And so when we're talking about this population, probably, one of the huge missing pieces is this very thing. So, and again, I alluded to that earlier, but we just don't have these conversations early enough, and it's not the right time when they come into the hospital. I think we can all agree on that. So we actually piloted this with Dr. Lucas probably a year and a half ago or a year ago with Health West Internal Medicine. So we had 2 physicians that really worked with her, and she worked on a community scale on the development of the NITO. And then we piloted it in an internal medicine office. So, the Dr. Reed and Dr. Bailey identified patients, and Dr. Hayes identified patients they thought could benefit from that conversation. And so we kind of worked through how does that process work in a 15-minute visit, and it doesn't. So what they would do is identify these patients, have the conversation with the patient, give them the information, take this home and read it. If you're interested in filling out a NITO form, bring your family back, and they had a separate 30, 45-minute meeting with the family to go over what the NITO was, the documents, the choices, all that kind of stuff. So, and I don't know if you guys have those of you that haven't, do you understand what it is? It's a living will on steroids, kind of. You really make the choice. These are the 4 choices that you make: the scope of treatment. Most people want everything done to try to save their lives, but you can decide, what do you want: intensive, general, or comfort care? When to stop medical treatment, your resuscitation status, and then long-term medically administered feeding. So there's kind of 4 parts on there. And, having that discussion with someone, you hope you're having it when they're healthy enough to really put a lot of thought into this. And they could change at any time. I mean, it can change at any time. We're lucky that we have it scanned into Cerner, so it's easily identified in the patient's chart. But we just had this discussion with our SNF team the other day. The facilities have them fill out a whole nother form. And so we're like, we got to get with them and talk about, if this is signed, that's not the time for you to do it. Why don't you check first before you have them sign it again? So we found a champion in our, because in the world I live in, it was like, well, whose responsibility is it to get this filled out? Primary care, specialists, oncologists, whose job is it? So everybody was like, well, not mine. So, sound familiar? And so we have a physician over in cardiology who said, I want to do this. And so he's piloting it and how they work through that over in cardiology right now. So at least we're starting to have an awareness and maybe a different comfort level about having the conversation, because I really think that's what it boils down to. It's not that primary care doesn't want to do it or specialist doesn't want to do it. They have, in ambulatory care, it's all about relationships, and so a lot of these providers just feel like if I have that conversation with my patient, well, they feel like I'm giving up on them. And so they are not comfortable having it. And we really feel like we're going to have to do a better job as an organization giving providers the tools on how to have this conversation, the time, the support in the clinic. So our care navigators and the staff over at cardiology, they're not going to initiate the conversation because a provider needs to do that, but we're going to facilitate the conversation and help support them and the family in having that discussion. And as you know, this gets really complicated because families don't agree, and then it's always kind of crisis time, and then we're trying to decide what to do. So if we can really involve the patient, the family, and get these decisions made early on, it's the right thing to do, and hopefully we'll be doing it more. So in ambulatory care, we're hoping that most planning's done while the patient's stable and that the family's involved. The NITO form is used. There's like wallet cards, and then there's the big document. It's bright yellow, and what we tell patients when they sign it is you tape that to your refrigerator. So if EMS comes to your house, EMS has been educated on NITO, and they need to look and see if the form's there, and then see what the patient's goals and what they signed. Because maybe they say, I don't want to go to the hospital, I'm just done, and I'm okay with that. So it's really, making everyone involved in the care of the patient aware of what their choices are. ED, hospitals, facilities. So for us, really our next steps are, like I said, the cardiac bundled payments. Methodist has entered into that. And for cardiology, our conditions are congestive heart failure, AMI, and then outpatient PCI. So we are trying to start it October 1st. We're a couple weeks into it, and we're trying to kind of find our way, just trying to keep track of the patients if they would enter into the bundle. And then we are on the hook for 90 days. So we need to make sure that we are micromanaging these people's care for 90 days, that they're not readmitted. And so how do we do that? And how do we do that as a health system? And we're kind of learning as we go, which I think, I just got back from a conference, and people across the country were there, and they said, yeah, we're learning as we go too. So it's, but it's something, it's good for us to venture into this, because it's probably going to become more common. And so we are doing that right now. We are working on our SNF preferred network. Protocol development, like I said, right now we have LASIX protocol. We have oral LASIX adjustment standing orders or protocol. And that's kind of where that ends for us right now. But we're really hoping the more that we get the APRNs involved in seeing these patients, and more involved in heart failure and a heart failure specific program, we will become more protocol based in the clinic with things. So we continue to explore our options for the expanded role of pharmacy and social work and integrated care. Like I talked about, that Lutheran Family Service, that 360 integrated care, I was like, wow, this is awesome. So I'm hoping that we can I'm hoping we can venture down that road a little bit. The new population health person for the health system, I just met with her yesterday, and those were things I definitely talked to her about, how we could partner as a health system and try to get some of those things in place. And I know Dr. Polich is very, very interested in those kind of programs. So continue to explore options for home monitoring and telemonitoring. So we had a pilot last year, I think last February, where we tried to do virtual visits with these patients. And how'd that go, Laura?
Did was spend 20 minutes on the phone trying to get them connected. So I was IT, and I am not IT.
It was, yeah, we were really hopeful that this would be, because everybody has an iPhone, but the patients they wanted to use their computer, probably because it was bigger, right? And us connecting to their computer was a nightmare. But I don't want to totally give up on it, because I do think it's a good idea. We could see the patient, we could talk to the patient, but we haven't figured out how that could be seamless and not take a lot of time. And remember, these guys have office visits, phone calls, and so it didn't work very well right now. We are now taking that over to our dietitians, and maybe have our dietitians do some virtual visits on nutritional education with diabetics and maybe heart failure patients too. So we're trying it. We're not giving up, but we definitely pulled it out of this group. The CardioMEMS is it's a internal monitoring system that's coming, and I think we'll be really involved in that. So it's kind of like the old Swan-Ganz catheters. So they put them in, and then the patient lays on a pillow, and then we would know when their pressures are going up before they even have symptoms. So the care navigators could go to, I don't know how this works. I think you go to a website and you look at their values, and then you go, oh, you need to come in, or we need to adjust something. So we're just going down that path. They're just talking about it, but I know that it's been approved to get it. So we'll see how that works. And then, when you go to national conferences and you see all the IT stuff that's happening with home monitoring, it's just mind-blowing, right? And so we'll see how much more of that we end up doing. And then continue to partner with hospital departments, SNF, home care agencies, and our ACO to coordinate our efforts. Collection of data and measuring outcomes. I don't know about you guys, but that seems to be a challenge always between Cerner and Crimson and the Cohen and the whatever. So we just keep trying to work on what it is we need, where do we get it, is it reliable, that type of thing. So we're working on those things. So that is our program in a nutshell. Like I said, Laura is one of our care navigators, so if you have specific questions, she could definitely answer them, but I'm open to any questions too.
I think that medications in the inpatient role is really difficult for us when they go home. Just the way that our discharge instructions are. I mean, it's just like a list of meds. And I'm from the acute care for elders unit, and so there can be 50 meds.
Yeah.
So in the clinics, have you guys found a way to, I mean, the pill packs are great, but is there a paper form that you guys use with a graph or anything that's better than just a list of medications to give patients that you guys have found has worked?
These guys have tried a couple different things. They've literally pulled stuff off the internet.
Yeah. Go in and find these sites that will put them into graph form for complicated people.
Yeah.
But I'm just wondering if you guys have found that.
No, not really. Honestly, that's where I think Elmwood is the answer.
Yeah.
I mean, meds are nightmare. And I don't know the inpatient setting, but honestly, I mean, there are days you just think, what happened at discharge? And I know you're 100%. I know they're telling you, but it is amazing what happens. And I don't care if they're going home or they're going to a SNF. I had a patient that left the hospital, and so I reviewed the whole list of meds with the SNF. The only med that wasn't on their list, which it was on the discharge, so it must have been in the transcribing onto their list, was furosemide. So in 5 days, they would have got furosemide when they came back. How does that work?
And we did a pilot on the inpatient role where a pharmacist would review at discharge the medications, because we weren't doing that previously. They would review after the physician had ordered stuff. And I think our stats show us that 40% of the time there were mistakes. We find correct. And so
I saw a discharge list the other day, and it had prednisone listed 3 times for 3 different doses. How is that possible? Why would you have 3 different doses of prednisone? So, and I think the other negative part, which we probably should spend time with each other, I don't know what the inpatient side, what you're looking at. I don't know, honestly, what the paperwork that the patient's looking at. I didn't come from that, but I don't know that. So I'm learning that stuff where, but I don't know that you know what our side looks like. So when we're trying to tell.
Yeah.
I said, if you ever want to sit down, we'll show you show us your stuff.
But so here I am talking to a patient that I'm trying to tell them, well, on your list, but then depending on where they were at, and if they were at their PCP list, how did they print their list off? And some of the lists can be printed off in medical jargon, like BID or TID, and then some of the lists are printed off in everyday language. So it's just even those small things, but at least the inpatient side has a resource of a pharmacist, and a social worker. So especially our biggest problem is the inhalers. They'll dismiss the patient with this, all these inhalers, and it's Friday at 4 o'clock, and they go to the pharmacist and they call us, and they can't afford any of them. Well, now what? I have no, and it's Friday, and I don't know which doctors will have a patient. You know, all those orders say that they're ordered by their PCP. Well, really, did the PCP order all the inhalers? Probably not. But they're the ones
PCP
that,
is a med rep.
right, the PCP
But
is
the
the med rep.
medications are probably ordered by a pulmonologist.
Yeah.
Absolutely, so now I gotta figure out which one. So it's, but
And they don't have any regard for what these medicines cost.
absolutely.
Well, we deal with that quite a bit.
Mhm. Mm-hmm.
Yeah, so just continue to really, we have to make them think about that. I mean, these are great drugs,
Nobody
but
can
guess
afford
what?
Brio.
If they can't
Yeah,
afford them,
yeah,
Nobody can afford
yeah,
Brio.
right.
yeah.
But the sad part is, you can't afford any of them.
I know, they're all.
They're terrible. So if we, even if we could get the process started on, do they need prior auth? Can you have the patient there? Can you print off the form that, so when they come in, they can bring us their income and we'll have it. But at least we've stepped up that process a little bit, so.
So Carrie Phillips and I we've worked on this for quite a while, just what the inpatient nurses see and what the outpatient nurses see, where it's set up by your position, and there's so many, I mean, it's just like, wait, why? Why can't we see the same thing? Yeah. Yeah, yeah. So, I don't know, it's a work in progress.
And just to clarify too, I appreciate that Lori said, you know, we're available like for referrals. But remember too, we can't manage every CHF patient. There was this push that they talked to the care managers and said, you know, we want the care navigators to follow every CHF patient. And ideally, that's really what should happen. But we still need either the pulmonologist or the cardiologist, their approval in the sense, please talk to them, because when there's issues, that's where we're going. And there's circumstances like some of these patients, honestly, their PCP is like 3 blocks away, and they listen to their PCP. And we're definitely having communication, but some of those instructions actually come better from the PCP than us, because they've been their doctors forever and ever and ever and ever. And, you know, it's kind of like, I just send a message to the PCP, this is what Dr. Casson would like to do. And then they tell the patient in the sense that they're there and they get their blood pressure checked there and they don't want to drive all the way down to Methodist. And that's how I manage that patient. Is basically he just, what do they think and what should I do? And so like Lori said, it's an individual thing. So I don't want you to think we don't want to follow every patient, but it's physically impossible. So that's where the health coaches at the PCP's office are trying to kind of take some of those lower risk, more stable patients. So again, it's the whole community.
Yeah, and I think having Terry there, Terry can kind of review things and say, is this a care navigator, is this a health coach patient, and then have the communication. Or sometimes the care navigators call the health coach and say, look, they're pretty stable, so I need you.
If the navigator is seen, if they've been deemed to be able to, you know, to be seen in the hospital, can the inpatient world see your guys' notes that, I mean, you put notes in on that?
Yes, yeah, yep. I think it says health coach note, high risk health coach note.
And may I ask, a wonderful program, what about the patients that go home and within 24 hours there's a phone call, the readmission, to prevent readmission? Is that the health coach, nurse, or who is making those
Health services.
calls? And is that communication, like this patient is now high risk, is that communicated to the navigator?
Mm-hmm. Yeah. So our MPC patients, the health coach calls. Non-MPC patients, the health services nurses call. We've been trying to work through that too. And sometimes we have the health coach calls and the care navigator calls. Sometimes they get 2 calls, but Yes, everyone's been instructed that these chronic conditions, when they come out of the hospital, they have to be on your radar, and we have expectations of how often if they're stable and not in an acute phase, how often you need to check in with them. If the care navigators are monitoring them, they're already high risk, and they are going to build that care plan based on how much support that patient needs.
And may I ask, do you know the average age of your patient in these programs?
Over 60.
I'd say, 70.
Mm-hmm. We have some young ones, or some in their 50s, but that's not.
I have 2 that are 38.
Oh. So. Yes.
Have you guys partnered with VNA? You know, they've got that telemonitoring at home where they do the vitals and the weights and it all gets downloaded.
We have not yet. But like I said, we do need to set up some meetings and really talk with the VNA about that and some other things too. So we know that there's some opportunity there. Yeah. Yeah. Yeah.
And we work a lot with the home care, like Kindred has the same program. And I think home nursing department.
Mm-hmm. Yep.
But the nice part is, like, they give the information, and then, so we can look at it every day. But we have a relationship with those home care nurses so that, like, when they make their visit, they call us. So the patient can some patients call their home care nurse, and then they call us, or sometimes the patient just calls them. But, yeah, we utilize it in a roundabout way. For them.
Well, thank you very much. Have a good day.